Well, good morning. I'm going to try to fill in for Dr. Wang. We missed him last night and we missed him this morning. He had a trip that he had to reschedule at the last minute, but this is part of the series of Wang visiting professors, which always focus on spine. It's an annual event and it's done through the generosity of Dr. Wang in terms of funding the lectureship. And so it's a pleasure to introduce friend and colleague, Dr. Dom Korek, who works in Charlotte, North Carolina at CNSA, Carolina Neurosurgery and Spine Associates. He's had an illustrious and continues to have an illustrious career in neurosurgery and in spine surgery. He served as the chief of neurosurgery at CMC for many years. He has also nationally served on a number of very important roles, including most recently at the Joint Spine Section. I can't remember, I think it was 3 or 4 years ago as president. He's been the president of ISAS. He's been on the board of the AANS. He started and has been basically a North Carolinian all his life. I guess he did undergrad at Duke, did his residency at Wake Forest, and then joined the Charlotte group soon afterwards. And the Charlotte group is amazing. I have some personal knowledge about it just because we have our second place there. It's one of the largest neurosurgical groups in the country. They have, 30, 35 faculty. They have a residency program that they just started recently. Not even that recently. It's probably in year 8 or 9 or something like that. And so we're going to hear about something that we really don't do very much of. So I'm anxious to hear the lecture on lumbar arthroplasty, anterior versus posterior. Welcome.
Thanks, Alan.
Awesome.
Fantastic. Thanks for the kind introduction. Thanks for having me here. It really is an honor. Not only you guys, kind of flagship program in neurosurgery and spine surgery in the country, but two of the nice guys and two of the national leaders, Alan and Mike, you guys are lucky to have. And so and they're personal friends of mine. And so this really is a treat for me. So thank you for having me and thank you for the kind introduction. It's going to be a little bit off the beaten path, not what you expect for a traditional kind of arthroplasty lecture. This is my disclosure. And that is Carolina Medical Center. And if we have a couple minutes at the end, Alan's asked me to talk about the new project that's going on, which is a kind of a $2 billion buildup that's going on in Charlotte. But we're going to talk about arthroplasty. And so the modern era of arthroplasty really was ushered in with the development of the Charité lumbar total disc replacement. And that Coke bottle looking thing at the top. Now, most of you guys don't, Alan I know remembers what Coke bottle caps actually looked like, but that's what a Coke bottle cap used to look like when you had to pop them off the tops. But that thing was the Charité 1 that was developed by Karen Buettner-Jans in East Berlin in the 1980s, and we'll talk about it in just a second. The Charité 3 was the third generation, obviously, and that's one of my early cases up there. And you see kind of flexion extension, good motion there. That was the first modern arthroplasty device to receive FDA approval in 2004. It really was met with not just a lot of fanfare, but even more controversy. And this thing triggered a lot of angst over the country in insurance and in carriers and in industry. And we'll talk a little bit about that. But I won't bore you with the history of arthroplasty. Like many things, you can trace it back to the 50s and 60s and Fernstrom balls and everything else. But this was really the first device that kind of defined the period of spinal arthroplasty. And the Spine Arthroplasty Society was founded in 2000, and that society was dedicated to basically motion preserving technologies. The motto is literally refuse to fuse. And this is interesting because it's 2000, right? There's no FDA approved devices of any kind yet. But it's been around in Europe and around the world for a couple decades at that point. Ultimately, Spine Arthroplasty Society was renamed as ISAS, the International Society for Advancement of Spine Surgery. And like Alan kindly mentioned, I was president several years ago, and Mike is president this year. Is going to have the meeting here in Miami. It's going to be a great meeting. Obviously, you guys all need to be there. But this is the I was lucky enough to be a moderator here, and this was in 2007. So this was the 20-year anniversary of Karen Buettner-Jans inventing the Charité artificial disc. And if you see here, Scott Blumenthal from TBI, Karen Buettner-Jans herself, Terry David, Louis Nell, Louis Pimenta. These are basically every single continent except Antarctica was recognized here. Alan hadn't conquered Antarctica at that point yet, so there was no representative from that continent. So this was the 20th anniversary, and this is Karen Buettner-Jans right here, who herself is a very interesting character. She was actually a gymnast for East Germany in 1972 and won gold medals in that Olympics in gymnastics. She went on to become an orthopedic spine surgeon and invented the Charité disc at Charité Hospital in East Berlin. So this actual event was held in East Berlin close to the Charité Hospital. So it was kind of cool. But this was kind of the very, height of exuberance surrounding lumbar arthroplasty. And so total disc replacement, which was an anterior approach, that exuberance kind of leaked over to posterior arthroplasty devices. And there were several lumbar facet replacement devices that were posterior arthroplasty devices that came into being in the mid 2000s. And those devices were the TFAS, the Acadia, and the original TOPS device. All three of those entered IDE study in the United States. And so this was an area of a lot of exuberance. There were a bunch of artificial discs come from the front, anterior retroperitoneal. Artificial facets come from the back. And this is one of the original TOPS cases that I did from the 2009 study. So there were two IDE trials. There was the original in 2007, 2009, and then there was a second one. The second one, and one of the reasons I'm here is it led to the first approval of a lumbar arthroplasty device in basically 8 years, and that was June of this year. So it not only was the first lumbar arthroplasty in 8 years, it was the first arthroplasty device to actually receive a superiority indication from the FDA. So it's not just a non-inferior, it actually was superior to TLIF, statistically speaking. Here's the anterior device. Is a cool device, biomechanically very robust, and we'll talk a little bit about that. So this is kind of our history with motion preservation, and it involves both lumbar and cervical disc replacement. So we started with our cervical disc replacement with the Bryan disc in 2002, and that thing was a bear to put in, no longer, thankfully, on the market. And then our most recent device in study right now, the Bagheera C study, which is ongoing, and this is the Simplify, and this is the Charité lumbar. Here are some of the posterior arthroplasty devices we were involved with. Here's the Acadia, we're involved with that IDE. Here's the TOPS device that received the FDA approval that we're talking about. And then here's True Position, which is just getting ready to close its IDE trial. So that, spoiler alert, has gone well and will likely be the second posterior arthroplasty device approved within just a couple of years after there's been a dry spell. So this is kind of our experience with motion preservation at CNSA. It goes back to several arthroplasties, lumbar arthroplasty, cervical arthroplasty studies, as well as disc repair. So we've been involved with basically about 20 IDE, IND studies, 10 of which we were lead site. This is kind of our dream team of folks here. This is Ginger, our current research coordinator, Peggy, our original research coordinator, and Turtle Sumic, my Croatian brother who's one of our physiatrists. But subsequently, after all this kind of splash that occurred, and a bunch of guys are too young, you guys were probably just about being born at that time, but there was a big splash that occurred in the early 2000s. And then there was kind of a cold blanket put on lumbar arthroplasty to a large degree. The lumbar devices had some issues associated with them, the total disc replacements, and all those posterior facet replacement devices failed to get through IDE study, and we'll talk a little bit about that in just a second. Conversely, cervical total disc replacement became the golden child of spinal arthroplasty. It had IDE study after IDE study in March. First one was 2006, 2007 with the Prestige ST. Last one was last year with the revised Pro Disc, the small keel, and the other Pro Disc devices, as well as the Simplify. And we have Bagheera in study right now. So it's been this constant march, and it's been success after success. There are 11 FDA-approved devices. There have been thousands of patients enrolled in level 1 studies. It really has gone right head to head with the gold standard ACDF and has kind of matched that gold standard. And again, here we see a bunch of the devices. This is the Bagheera, which is still in study. It's a nice device. This is Simplify, which is a peak-on-peak device, which is the latest FDA approval. Here's M6, which has had some issues with osteolysis. And if we have a moment, we'll talk about that. And then here's Mobi-C, which is currently still the most used device in the United States. So again, bunch of different devices, and has done really well. So what happened to lumbar arthroplasty? What you guys, Alan mentioned you guys don't really do it, and we were talking a little bit earlier. I was talking with Damien. He's like, not a lot done in the area, and there's really not a lot done in the United States. So Charité 3, I was lucky enough to be on the design team with Karen Buchner-Janz and with a couple other folks, including Jürgen Harms and some real luminaries in spine surgery, to develop the Charité 4, which is called the Charité Evolution. It's a kind of cool looking device. You may not recognize it because it never made it to market because of all the issues that was with Charité. They basically, even though we came up with a disc, it never was brought into the market. The Pro Disc became FDA approved, but then subsequently these 3 discs were withdrawn after their ID studies were finished. So they were never even submitted to the FDA. They were all metal on metal. Here's the Kineflex, which we were involved with that, and metal on metal. Here's the Maverick, metal on metal. And then the newer devices like the Mobi Disc, which is this guy right here, or the Freedom disc, which is an elastomeric disc. They have CE marks and no FDA approvals in the United States. So there are really only 2 FDA approved devices for lumbar total disc replacement, the last one being the Activell in 2015. So that was a while ago. And so if you compare it to cervical arthroplasty, it's really in contradistinction to how cervical arthroplasty is done. So the same can be said for the posterior devices. So with the posterior devices, lumbar facet replacement, the TOP study was stopped in 2009. The original, because as you remember, 2009 was the Great Recession, and a lot of these ID studies were being done by smaller companies, and they just didn't have the money to go through, and so all of them fell off the way. So TOPS, TFAS, and Acadia all basically, none of them finished ID study. TOPS kind of came back as a success story. It was redesigned. The original guy who brought it to market got back the IP, started a new company, got it CE mark, got use in Israel and in Australia and in Europe. And then with the money that he got there, he came back in ID study in the United States, superiority study, and that is the device that has the approval. So you say, okay, well, that's where we stand now. We have only 2 devices in the lumbar spine, last one 8 years ago. Anteriorly, posteriorly, we have just 1 FDA approval, which is just a couple months ago, and then 1 in study right now. So the question is why? Why did lumbar arthroplasty, after such a kind of promising start, go away? And I'll tell you, I think there are 2 primary reasons, and 1 is indication, and 2 is approach. And so this is one of my actual Charité off-label cases over here. And so you can see this is a complex anatomy. If you look at this thing, it's a 2-level anterior retroperitoneal approach. Here's a very angry looking ureter that's right in your field. Here's all the guts and everything in the perineum that I try to avoid because I don't like guts. That's why I didn't go into general surgery. The smell is disgusting. Here's the iliac artery. Here's the iliac vein. Even worse, you get into an artery, you can lose a liter in about a minute, but at least you can repair it. You get into the vein, you lose 2 liters in a minute, and you can't repair it. You just kind of have to tamponade it off, and then when you do repair it, you get blood clots. So this is a relatively precarious approach even the first time around. Second time around, it becomes even more difficult to revise this sucker. So again, this is not the workhorse approach to the lumbar spine. We do anterior surgery. I do ALIF, and I'm sure you guys have your share of anterior, but it's not the workhorse approach. The workhorse approach is the posterior. You don't see any guts up here. You don't see any iliac arteries or veins. you got a bunch of muscle and kind of a standard approach that everybody, even, first and second years have some facility in being able to at least start this kind of approach. So workhorse approach posterior in the lumbar spine, workhorse approach not anterior. Artificial disc indicated for low back pain, a very controversial indication, right? People don't necessarily want us operating on low back pain. And insurance companies, were scared about people coming in off the sidelines, and all of a sudden, everyone who had my back hurts, the 100 million people in the United States whose back hurts, were all going to get artificial discs. And so that was some of the regulatory and insurance problems that they ran into. And whereas the posterior approach, the indication for artificial facet is primarily spondylolisthesis and stenosis. Now, pretty much everybody would agree that, that there is an operative indication there when it's recalcitrant to non-surgical management. And there's some controversy whether it's decompression alone versus decompression infusion. But most people would agree that this is a legitimate surgical indication, whereas you don't get the same for necessarily for degenerative disc disease, black disc disease, and mechanical low back pain. So much like artificial discs and most operations, there's a sweet spot concerning the indications for total disc arthroplasty. And that sweet spot is patients who need an operation and they have an element of instability that will become more unstable if you decompress them alone. So you basically have a situation where you can do too little, you do decompression and you under decompress because you're trying to maintain stability, or you have a situation where the disc is totally fused and you can't really get motion back. So there is such a thing as too good a disc space and then too bad a disc space. And so this sweet spot for facet replacement is kind of this moderate mobile spondylolisthesis and stenosis. And again, something that typically most people would say deserves an operation. So this is really the ideal indication. This is one of my patients, and you see, a disc at 4-5 doesn't look great, but there's still something left to the disc. It's not bone on bone. You see the pathology is obvious both on the MRI and the CT. So everyone typically becomes symptomatic with the stenosis. But you can see this thing that caused this stenosis is the bad facets here. So the facets go bad. The body understands there's some element of glacial instability there. It lays extra bone and ligament down. It causes stenosis. Patients present with radiculopathy or neurogenic claudication. But the true problem are the facets. And so if you do a decompression alone, that's not doing jack for the true problem. In fact, you can argue that that's exacerbating the problem because you're now taking away some of those secondary stabilizing structures. So that's kind of the ideal indication for facet arthroplasty. Like anything else, there are contraindications, and you can't be afraid of failure. Like the quote there kind of indicates, you have to learn from your failures, but you also have to try to minimize those complications and those failures. And these are stuff that shouldn't be addressed with posterior lumbar arthroplasty. In other words, if you have a stable disc, if it's kind of fused already, you can decompress it because it's not immobile, it's a fixed spondylolisthesis. If you have primarily my back hurts as opposed to neurogenic claudication or radiculopathy, osteoporosis, scoliosis, et cetera, is pretty straightforward relative contraindications. This is the current TOPS device, which, like I talked about, is a biomechanically very robust device. It is similar to the original device. It's just about a third smaller, and it's getting smaller as time goes on. Like I said, the interesting thing here is that there's a really long-term follow-up from Europe and from Middle East and from Australia, and now a superiority claim versus TLIF in the United States. So it really is kind of changing. And so this is kind of a picture of one of the patients and one of my residents who's now one of our partners at CNSA, Vince Rossi, took this. This is one of the case that he and I did together. One of the reasons the patients do well is this operation forces you to do a good decompression. You could see the thecal sac here. Everything is gone. PAR is gone. Posterior element's gone. You got thecal sac from L4 to L5. You go nerve root to nerve root. pedicle to pedicle, and now you see putting the device in. You're not doing interbody fusion, so it actually is less blood loss, less time. There's a little fiddle factor, but it's really not that bad. It took, at the end of it, we're doing these in about an hour and a half, and I'm not one of these look how fast I am kind of guys. I'm one of these like get it right when you're in there kind of guys. And so that's putting the device together, which is done on the back table. Here it is going in, and it's called posterior total replacement because you replace the posterior element. So patients are always saying to me, well, you're taking that stuff out of there. What are you putting back in there? And you say, well, nothing. And now you are putting something back in there that actually protects the dura and everything else. So that was one of our cases. That was real time. No, that was sped up. And that's me and Vince actually doing the case. So it's really the learning curve. I would put it at like 3 to 5 cases. This is the first look result. So the way the trial was designed was Bayesian statistics. So that's a probability. So you're able to take looks at the data in pre-ordained kind of intervals. So the first one, the very first preordained interval was 270 patients. And the data was so strong that they just stopped the study and they got the superiority claim. We published that first 270 patients. Subsequently, they finished at 300 because there were patients that were floating around that were being done. So the final cohort was 300 patients. The takeaway message, the overall composite measure for clinical success was statistically significantly higher, so superior, 77% to 24% for fusion. You say, wait a minute, fusion may not be a great operation, but I do better than the 24%, and we're going to explain that in just a second. The other thing to look at is a pure clinical, and that is a pure clinical indice, which is the Oswestry Disability Scale, 15-point improvement in that. And that showed statistically higher 15-point improvement, 94% to 80%. So that's more of kind of the real kind of clinical outcome. And then this study was the complete study, which is referenced there, that was done, that was published as well. So this is the breakdown: 302 patients. You see the 2 different arms. It was a 2-to-1 randomization, minimal 2-year follow-up. And you see the endpoints, and that's the key thing. You see inclusion, exclusion criteria, pretty standard stuff. Demographics were almost identical, no statistical differences in operative time, blood loss, or any of those things that you would expect. This is kind of where the rubber meets the road. So we mentioned this composite measure. The FDA is the one who comes up with this composite measure. So you can only be a success if you have all 6 of these things. That's where that 80% versus 24% number came. So you can't have any reoperations or any lumbar injections afterwards. You have to have an ODI reduction of at least 15 points, which is significant. You can't have any worsening neurological deficits, no AE, and no fusion failure or instrumentation failure with the device. You're obviously concerned about loosening, because when Alan and I were training, everyone's like, instrumentation is temporary. It will always fail. What makes it permanent is the fusion. How many times did you hear that, Alan? And so why does this not fail? Because it's not trying to hold something still that doesn't want to be held still. That's why when fusions fail, instrumentation fails, because you're doing something the body doesn't want to do. Here, the body wants to be moving there and it's letting it move. So there's just not the same stress on the screws. Like I said, I got patients dating back to 2007. So I've got 15-year follow-up in some of my patients. And I literally have not seen a screw loosen. It's not that one hasn't in the world. The rate is like 0.1%, but I literally have not seen any of my 60 patients who have screw loosening. So it is a biomechanically robust device. And so if you look at that 77 to 24%, that's where the number comes from. And here's the breakdown. And when I say breakdown, what I'm talking about is each one of those individual scales. So this is the ones with no repeat operation, ODI reduction, et cetera. So here's the overall, but you can see this fusion status failure is big because that was basically for fusion, they wanted to be fused by 2 years, and it was sent to Medical Metrics, an independent core lab. And if their blinded guy said it was fused, then it was fused. If they said it wasn't fused, it wasn't fused. And they only had a quote unquote solid radiographic fusion in 56% of the patients. We don't always look for solid radiographic fusions. We look for failed instrumentation and everything else. So that can be misleading. So because of that, we said, well, let's pull out the fusion status. Let's take that criteria. The FDA want us to do these 6. Let's just do 5 and throw that fusion criteria out the window and just go with the 5. If you do that, you have a success rate, still a composite success rate of 53% in the fusion. A lot of that was repeat lumbar injections, which we didn't see in the top study. And so you still had a 77 to 53, 54%, still statistically significantly superior and still phenomenal results, even when you take that fusion criteria and you throw it out. So here's what you see with ODI, and we're all used to that curve, but you see the fusion curve in gray, you see the TOPS curve in blue, and you see it's much better, or even though they both are statistically better than baseline, it is better in the TOPS crew. And you see this in everything, in the VAS back score, same kind of thing. You see it VAS leg score. And subsequent surgical interventions. And so at the end of the day, where the rubber meets the road, you don't want to have a repeat operation. And there were fewer repeat operations in the TOPS crew. Some of those, like Yoda talked about, you're going to have failures, but Yoda was around for 800 years, so I'm sure he saw his fair share. But the point is that you can cut down on those to a large degree. In other words, retained surgical drain, that is someone sewing in the hemovac. Like, you don't need to do that. You could take 2 seconds to look at the hemovac. So you're going to have your failures and your complications you should learn from, but there's some you should not necessarily should border on never events. So that's kind of the story of TOPS and anterior versus posterior arthroplasty. I'm going to go into a little bit more, but before I talk about some of the esoterica, some of the philosophy, any questions about any of that up to this point? And I've got a little bit more to do with the lumbar arthroplasty.
No, I mean, that's very impressive. I guess my 2 questions are that adjacent level disease, that's probably something that people would want to hear is better in an arthroplasty. And it looked like it was even a very short term. But you have like 15-year experience.
Right.
Talking about, do you think it makes a difference?
Great question. And so the short answer is yes. The long answer is it's very difficult to show that. And in order to show, and the reason is, and Damien, I'm going to do it. I'm going to pick on you, man. What is the adjacent level reoperation rate after ACDF? What, if you had to tell your patient what a number, a percentage, what number would you throw out? Per year. That's high per year. What's that? Yeah, and so the number that everyone throws around, if I asked Alan, I can't pimp Alan because he's my buddy and he knows more than I do. It's the number people typically come up with is 2.73% because that's Hillebrand's number. Hillebrand's kind of landmark paper from 1999, I believe it was 98, 99, and he looked at Bowman's series of ACDF. And that is one of the most commonly quoted and one of the commonly misquoted articles in the history of spine surgery. The number that is the headline number of that was 2.7%, and people round up to 3% per year. But the reality is, if you look in the data, the adjacent level reoperation rate was 0.66%. So let's round up to 0.7. So it was significantly less than 1%. Where'd that 2.7%, 3% number come from? Alan Hillebrand said, we're going to define adjacent level disease, not as adjacent level reoperation, but as adjacent level reoperation plus anyone coming back to the doctor with a complaints referable to the adjacent level greater than 6 months post-surgery. So that's a totally non-validated criteria. He just made it up. You talk to Alan Hillebrand, he was like, I just made it up. And yet, if that were put in for publication today, it would be thrown out because that's not a problem. It's not a patient-reported outcome measure. It's not a validated measure. He just threw that out there. And the number we care about is not whether you go to the doctor with complaints referable to the adjacent level, which is impossible to determine, especially in a retrospective study, is the reoperation rate. So what is that rate from Hillebrand? It's 0.7%. The reason I'm coming around to the question, Alan, the reason this is pertinent to the question that was asked is it's low. And so if something is that low, if you're going to statistically power a study with a 0.7% per year, you would have to have a 0% a year for like 10 years for a standard 200 or 300 person study. So you have to have a longitudinal study for 10 years, which nobody has, or you have to enroll like 7,000 patients. I went to our statistician and I asked that question. I said, 0.7% per year. If I want to show a difference, a statistically significant difference at 0.2, which is essentially zero, and that's asking a lot because adjacent level disease, some of it's not just the process, some of it's the natural history. She said, yeah, you got to enroll 10,000 patients for a 2-year study, and no one is doing that. So the rate is so low that the standard 2-year follow-ups don't typically show adjacent level because at 2 years, you would expect a 1.4% rate of reoperation in the cervical spine anyway. And the reason I use that because that's been that's been better characterized than lumbar, but the rate is lower than you think it is. And so you can't really show that at a 2-year follow-up with several hundred patients. What you need is a meta-analysis that has several thousand patients, or you have longitudinal study where you follow your patients 10, 15 years out. I have followed my patients 10 or 15 years out. I still see those patients from 2002, my Brian patients. And that's why I answered your question, a little tentatively. It is yes, but the proof is not as strong as you would think it is because all this data from the ID studies don't follow out that long. So you'll only show it with a meta-analysis. So the reoperation rates are small, so it's difficult to prove that early on. Does that make sense? Yeah.
The only other question or point is, I think something that turned me off anterior artificial disc. I remember going to a spine section meeting and there was a guy, an ortho guy from Johns Hopkins who specialized in arthroplasty revisions. And I can't remember his name, but he just told me like what was involved.
Yeah.
And it was, and they lost some patients.
Yeah.
Died. And so for back pain, it was like, I don't.
And I agree with that. A lot of these patients are younger, retrograde ejaculation, temporary 5%, permanent 1 or 2%. That's a complication that's kind of off the beaten path, but significant in that patient population. It's not all that bad. I've done anterior revisions. Obviously, I have a revision surgeon, but I don't just leave and let my revision surgeon do, when I'm doing my standard exposures, whether it's revision or index procedure, I'm there with him. And we've done a handful of revisions. It is a pain, but it's not undoable. I know who you're referring to. And he talks about, well, we put stents in the ureter and, and we float catheters into the iliacs and we're ready to blow them up and all. We don't do any of that. We just do a transperitoneal approach instead of a retroperitoneal approach. And so there's more ileus and everything else, but you can find that plane. It is a bear. When I put in my index surgery from anterior approaches with artificial disc, I always put a Gore-Tex pad in because that leaves a plane between the disc and the iliacs, which is the key thing. And that's the one thing that I kind of do differently. But I'd be lying if I didn't tell you it's a pain in the ass. And so that is one of the reasons it didn't catch on. Getting back to this concept of lumbar spondylolisthesis, this is an area of controversy as well. And that controversy, a lot of it, and I could give a talk only on this, is the Swedish study and the Norwegian studies. Turns out the Northern Europeans, they do a phenomenal job of following their patients. They have these registries and they follow like every patient, but they don't really like to operate much. And like if you're in Europe, I went to a CSRS meeting in Europe and I got into this huge argument with this nice lady spine surgeon who now hates me because I did the American, like when you challenge me, that is a debate now, it's on. And so she, we kind of went back and forth and we were talking about should you operate on somebody with cervical stenosis, signal change in the cord and myelopathy, essentially early myelopathy? And she was like, no, you don't need to operate on those patients. I'm like, my God, if you don't operate on that, those patients, what patients are you operating on? But there is definitely a different philosophy with especially the Northern Europeans compared to the US. Here's the SLIP study that was done by Zoe Gogolwala. These are all New England Journal of Medicine. Okay, so New England Journal of Medicine is, supposedly the highest kind of thing. And I have been a reviewer for New England Journal, and they do have a very high standard. The Swedish and Norwegian study basically said decompression alone and fusion, same thing. You don't ever need to do a fusion. The results are the same. Zoe came out and said, no, hold on a second. Fusion, you have a reoperation rate. Not only are you statistically better with ODI, and these are ODI scores, but the reoperation rate is about 14% at 2 years, 2 to 4 years for fusion. The reoperation rate for decompression alone is with these guys was about 30%. So there's a huge reoperation rate here. And they basically said the reoperation rate was the same in both of these. Zoe said the reoperation rate was 30% with decompression alone, but only about 14% in decompression and fusion. And that's kind of where the rubber meets the road. So with spondylolisthesis, there is such a thing. You have decompression alone, and that can be seen as too little of an operation, especially with a mobile spondylolisthesis, and you have decompression and fusion, which can be seen as too much operation. So kind of the TOPS device is a dynamic stabilization. So I see it as kind of the Goldilocks baby bear solution. Mama bear is, decompression alone, daddy bear is decompression and fusion. That kind of that Goldilocks, that right in the middle is a dynamic stabilization. So it allows you to do that aggressive decompression that sometimes isn't done when you're trying to do a decompression alone because you're worried about preserving stability. So you get an aggressive decompression, and then you also get a stabilization, but it's a dynamic or normal stabilization as opposed to a holding the body still when it doesn't want to be held still. And getting back to this, what we did here, these are all statistically different pools, so you can't directly compare ODIs, but these are ODI improvement at 2 years from baseline. So you can see the improvement in the decompression alone was pretty minimal. In decompression and fusion in the Northern European studies was pretty minimal, but here with the US study, with Zoe Gogolwala study, the SLIP study, it was much better. But look at the fusion rate here. So the control rate in the top study was where we expect it to be. So this control arm really functioned very well from an operative perspective, but the TOPS blew it out of the water. And then compared to the TOPS ODI improvement, compared to what we're seeing for decompression alone, it does bring in that kind of Goldilocks potential procedure. Maybe this is the kind of just right procedure. So this is a standard patient. So we'll kind of walk you through it. It's one of my patients that I did. I'm a huge college basketball fan, and this is actually the wife of a former All-American basketball player, and so ACC basketball player. And so the two worst things are VIPs or doctors or nurses to operate on, and this fell in one of those categories. Classic stuff, recalcitrant, you see this mobile spondylolisthesis. And, and like most of my patients, you're playing the long game. You don't just rush everyone to the operating room. So here she is in 2018, and she was starting to go bad. The sets didn't look good. She had significant stenosis, but we goosed her along. We didn't rush her to the operating room, but she ended up getting progressively worse. SLIP got worse. Stenosis got worse. So she undergoes the TOPS, and those are the actual intraoperative films you see. That's an AP and a lateral fluoro. And then here's the post-op, the flexion extension films, nice motion. You see she still has a slip here. The arthroplasty devices lets the spine go to where it wants to go. It's not stopping it from going anywhere. It's giving it dynamic stabilization. But that's the point. This is a constrained motion now, where before it was an unconstrained, and you see the decompression that it forces you to do. It's just this phenomenal decompression, and I think that's why the patients do so well from the radiculopathy neurogenic claudication perspective. So where we're going to go with facet replacement, TOPS total facet replacement is FDA approved for L2 to L5, not L5S1. They do have a device that's coming out at L5S1. This is a hybrid. This is off-label. This was done in Europe, but you can see a fusion here at 5.1 with the topping off. And this makes sense to a lot of people, this concept of fusion, no motion, constrained motion with the device, and then regular motion above that to get to what Alan was talking about, adjacent level disease, potentially cut down on that. You can never make it go away completely because, again, there's a natural history of that. People are talking about doing hybrid kinds of thing with the total disc replacement in the front when the disc is totally shot and the facets are shot in the back. And then making this more MIS, you could see from the way that we put in, I like the big decompression, but you can't really do that MIS, and the device is put in a unitary fashion. They're basically chopping it in half so you can put it in from two Wilsey approaches. So they're kind of working on that. To me, that's exciting because it is kind of a new era of arthroplasty. Like many things in life, they're iterative. Progress is iterative, and it comes in stops and goes. And the reality is that there was this tremendous enthusiasm for total disc replacement, but it wasn't a good fit for the lumbar spine because the anterior retroperitoneal approach is not the workhorse approach to the lumbar spine. The posterior is, like the anterior is in the cervical spine, and it treats posterior decompression spondylolisthesis and stenosis. It treats an entity, radiculopathy, neurogenic claudication, that most people would agree needs to be treated. Like cervical arthroplasty, it treats radiculopathy. It doesn't treat my neck hurts or my back hurts. So the right indication, the right approach, I think this is going to open up arthroplasty right from the start. I think you're going to see True Position be FDA approved. We haven't had an FDA approval in 7 years. We'll have probably 2 within 2 years, and maybe off and running where we can get some movement in the lumbar spine that is similar to what we see with cervical arthroplasty, and can really get to not just clinical improvement, but also decreased adjacent level disease. Again, as I look at my experience with the kind of the lumbar spine, I've done plenty of total disc replacements and A-lifts, but this is the anterior approach. Those are the iliacs. That is a problem. Here's your lateral approach. That's the psoas. That's a bunch of nervy stuff in there in the lumbar plexus, femoral nerve. Here is the posterior approach. That's where all the pathology is. Willie Sutton, why do you rob banks? Because that's where the money is. Why do you take the posterior approach in the lumbar spine? Because that's where the pathology is. So you're operating on something that needs to be operated on, that payers will pay for, that people understand needs an operation. You're taking an approach that is the workhorse approach that decreases initial morbidity, increases clinical success, and is revisable. So thanks. That's the lumbar arthroplasty update. And like I said, I hope this opens up kind of a new era of lumbar arthroplasty as we get into posterior facet devices and really get at that adjacent level disease issue. Any questions about all that?
Contraindication was a stable spondylolisthesis. Where do you kind of draw the line on that?
There isn't an evidence-based line. I usually like to see about 3 or 4 millimeters of motion. If they're 0 motion or 1 millimeter of motion, I typically say, and then I look at the CT scan, and if the facets are arthrodesed or it's kind of bone on bone, the TOPS device needs some disc there because it's got to fit pedicle to pedicle. And so you can't have a totally collapsed down disc, and it doesn't make sense when it's moving. So I get flexion extension films is the short answer. Flexion extension films and 0 or 1 millimeter movement, to me, that's a stable spondylolisthesis. Any other questions? Yeah.
Dr. Cork, thank you so much for the very interesting talk. I had a quick question in regards to patients that have received the TOPS procedure. Have you had any patients that needed then crossover to fusion, like removal of that and then fuse them? And what does that patient look like in your experience?
Yeah, you fell right into the trap. Thank you.
You're welcome, sir.
That's, you set me up. But to your point earlier, Alan, that is a nothing revision. That is a posterior approach. There's no ureter, there's no iliac. You do it yourself. You don't need to approach surgeon. I have done it. I've never done it for a failure of the device or for a loosening of the device, but I have done it for adjacent level disease because again, there's a natural history there. You're not putting extra stress on the adjacent levels, but that initial level wore out without any adjacent stress. So other ones will wear out as well. My idea was I do a lot of revision as most, quote unquote, complex spine guys do. I don't like cobbling together like 5 different systems. So I typically just take all that old crap out, put new stuff in and kind of make it so the next guy doesn't have that disaster of dealing with 3 different systems and, which was what. And so my idea was I'll just go in there and I will whip out the device and I'll take out the screws and I'll put in bigger screws and do a fusion. So the tulips are turned in TOPS, they're turned this way because the device articulates medial to lateral as opposed to caudal to cephalad. So you just turn, so I said, I'll pull these out. So I take the device out, which is easy to do. You just pop out 4 locking screws, device pops out, and then those screws aren't coming out. It turns out they're hydroxyapatite sprayed, and I was afraid that I was going to break the bone taking out. And so what I did was I just turned the tulip heads, caudal cephalad, put in 2 extra screws and then rods, rigid rods the whole way. And it is a piece of cake revision, comparatively speaking, to anterior, and that goes with the traditional approach. So just take that off the board. That it's actually easier than a standard, redo fusion or, and I typically don't redo by getting into the inner body space. If I felt like I had to, I probably would do an anterior posterior kind of thing, but it's an easy revision is the bottom line. Any other? We got a couple minutes, I think, Alan. I'm happy to throw up the stuff. Yeah, we got the second one. Thanks. Thanks again, guys. It really is a pleasure to be here. Alan and Mike are, again, you guys are lucky to have that kind of faculty. And they're phenomenal guys and phenomenal surgeons. And it really is a pleasure to be here. And thank you for having me, Alan. Thank you. All right. So I'm kind of at the point of my career where I'm kind of transitioning to more of an administrative kind of position. So I actually am a 0.4. I was telling this to Alan yesterday. A 0.4 employee of Atrium. So basically transitioning from Atrium to CNSA, although CNSA, I still have my office that I have for 25 years. They haven't kicked me out or anything. And I have good, excellent terms with everyone there. Like I said, I still hang out in my office at CNSA and I never check my Atrium email. And so I miss a bunch of meetings and they get mad at me for that. But I am the, quote unquote, medical director of the Southeast Region Spine Center of Excellence. And what that encompasses is spine. Is a slide at the end of this that it basically is the Charlotte region, the greater Charlotte region, which is about 10 hospitals in the greater Charlotte region. Wake Forest, which is where I did my residency and trained, which is now owned by the Atrium system. And then the Florida, the hospitals in Georgia, Navicin and Floyd. And then now the Advocate Aurora hospitals in Wisconsin and Illinois. So it's become this $34 billion hospital system, 4th largest in the United States. And it's really quite the monster. So my job is to coordinate spine through all of that. And and one of the things, without getting into the weeds of it, that I told them that I would only do this job if it was all spine, ortho and neuro, so agnostic to whether ortho trained or neuro trained, spine is spine. And it was surgical and non-surgical because everything is continuum and you can't affect something downstream if you don't have the ability to affect it upstream or further downstream. So it encompasses non-surgical, pain management, anesthesiologist, physiatrist, physical therapy, ortho, neuro. And so that's the kind of the concept of the Atrium Center for Excellence. Atrium is building in Charlotte, which is the center of the entire Atrium network, Carolinas Medical System, a $2 billion project that is building a new medical center, the first medical center in Charlotte. Charlotte's the largest city in the United States that doesn't have a medical school. That's going to be solved as of not this summer 25. And at the same time, they're building this research facility. It's called the ERCAD Training Center. ERCAD is this training center that started in Europe. It's mostly general surgery, but basically they have thousands of surgeons that come through these centers. There's one in Europe, one in the Middle East, one in Africa, one in South America. There's none in North America right now. And they get thousands of surgeons that come and get trained every week, basically. So it's kind of this destination. It has live animal vivarium. It has, cadaver. It has robotics. It's really quite the facility. So, Alan, this. This is Charlotte. And so this is downtown Charlotte, which they call uptown, kind of inexplicably. Here's the football stadium. And here is where CMC is right here. So here's downtown. So this area here is about a 5-minute walk from basically uptown/downtown to Carolinas Medical Center. So they're not only redoing this area, they're putting in a new hospital tower that's going to have 12 neurosurgery dedicated ORs and a new rehab center. But in this area here, the Pearl, they're building this medical school and ERCAD training center that is this $2 billion project. So this is how the real picture of Charlotte looks. This is downtown, uptown Charlotte right here. Here's where the existing hospital is. And you can see here in between, there's a lot of green and not that much going on. And if you go to the next slide, that's how this sucker is going to look in a couple of years. So basically, it's going to be anchored by this area right here that has the new medical school and the ERCAD training center. It's going to link downtown to the existing Carolinas Medical Center. This is in real time. This is a picture as of September, just a couple months ago, and you see there's a tremendous amount of building going on. This guy is going to be the new medical school right here. They're going to have some academic offices up here. This is the actual medical school itself. This giant thing is going to be the ERCAD training center. It's going to have ultimately 7 floors of all the things that I just talked about. And then it's going to expand. This innovation corridor is going to expand through this entire area right here. So it's well on its way. It's going to be done in summer of 2025. That's how the ERCAD center is going to look. You're going to have the surgical training. And like I said, there's going to be a vivarium. There's going to be a cadaver lab and all this stuff. Here's how the medical school is going to look. It's going to be, here's the medical school, 370,000 square feet, 320 for ERCAD North America. And here is kind of what it's doing. It's creating 5,000 jobs on site, ultimately over 11,000 jobs in Charlotte right now. Believe it or not, Charlotte for the last 20 years is the #2 banking center in the United States. #1 is New York. #2 is not Miami, Chicago, LA, it's Charlotte. Charlotte boomed because of the banks, and then the healthcare center system followed it, and we followed it at CNSA. We do have 43 surgeons now at CNSA, so we have kind of grown like I said, there wasn't a medical school there, so we were the private-demic. We were a private practice group who covered this medical center that now is becoming an academic center. It is basically a $2 billion project. And this is how it's going to look. This is going to be the Wake Forest University School of Medicine Charlotte campus. So the medical school and the residency are going to stay totally separate. Wake Forest is going to have their Winston-Salem Medical School, and it's going to be called Wake Forest University Baptist Medical School. They're going to have their own residency, which they have. We're going to have our residency, which we've had for 10 years now. And the medical school, you were going to apply differently to each medical school, like they were totally separate entities. So 2 separate entities, and that's how the artist rendering has it kind of looking. There's this creepy kind of like virtual skeleton that's hanging out here in this person's training, but it's going to be kind of state-of-the-art kind of stuff. And this is really how it is going to look. And it's kind of cool because you can see with that infrastructure that you can actually see now in your mind's eye that it is going to kind of look like that. ERCAD, like I said, is a thing. I'd never heard of it personally. I'm sure you haven't, because we don't really hang out in Europe with general surgeons. But it is this phenomenal thing where surgeons from all over Europe and Middle East and Asia come to train at these centers. There's one in France, there's one in forgot where it is in the Middle East, and then there's one in Africa, and the newest one is in South America and Brazil, and then this is going to be the first North America. And it's going to, be kind of state of the art kind of stuff, as opposed to Europe, which is about 80% general surgeons coming through there. It's really going to be 80% musculoskeletal, which means spine and total joint. So that kind of gets flipped on its head a little bit. That's going to be the wicked cool sterile thing that some dude giving a lecture like Grand Rounds lecture with people trying to stay awake like you guys. So again, that's how this is going to be the first phase. Here's the medical school, here's the ERCAD center, but ultimately all this is going to be filled in. So there's stuff going on. Siemens is committed to be an anchor tenant. Basically, it's like a mall with Nordstrom's. Siemens is going to be the Nordstrom. Medtronic and Stryker are both talking about being the Saks Fifth Ave. They're basically ponying up like $30 million to be named sponsor. They're going to have their stuff parked in there all the time. But you can see this is not going to be a general surgery thing like it is. It's general surgery and OBGYN in Europe. Here it's going to be spine and musculoskeletal based. So it's going to be kind of cool. Any questions about that thing? This is what the system kind of looks like with we started out here in Charlotte. Charlotte, Spine First in the greater Charlotte area, Wake Forest, Navicent, and then it's going to be Advocate. Again, that's all I got for you. I appreciate it, Alan. Thank you for your time this morning. You guys are great.